Hello, everyone. My name is Jennifer Quinones, and I am an adult geriatric primary care nurse practitioner student here at William Patterson University. And today I will be presenting on a patient with COPD. To start, the patient arrived into the office for an annual visit. However, when the patient arrived, patient had complained that they had a new cough for the past 3 days, and since they were in the office already for an annual visit, they wanted to also talk about what was going on with this new cough and what we can do about it. So our patient today, he is a 93-year-old Hispanic male. He arrived for a wellness visit. However, he does have complaints of a productive cough with nasal congestion that he's had for the past 3 days. He does share a concern due to his history of COPD, which is understandable having these kinds of symptoms present when you are living with this chronic respiratory disease. He does, however, deny any fevers, any chills, any sore throat, malaise, any worsened shortness of breath or chest pain, and he does deny any recent travel or sick contact. Patient does have a past medical history. He was diagnosed of COPD, hypertension, paroxysmal atrial fibrillation, congestive heart failure, chronic kidney disease, stage 3B, type 2 diabetes. Patient denies any past surgical history. So the patient's vital signs were blood pressure was 110/61, heart rate 52, respirations were 19. His O2 saturation was 97% on room air. He weighs 170 pounds. He is 5'7" for his height and BMI 26.6. It is, however, very important to note the patient is oxygen dependent at home on 2 liters nasal cannula. He did not arrive with oxygen as he and his daughter report that he only uses oxygen around the house because even though his oxygen sat at rest is 97%, which is confirmed, when he exerts himself, his oxygen saturation drops to 87% on room air. So he uses oxygen at home whenever he is moving around the house. So the patient denies any allergies to any medications. He is on Beztree Aerosphere, which is a combination LABA/LAMA ICS. He is having his diabetes managed with Tradjenta, Jardiance, and metformin. He is on Eliquis to help with his atrial fibrillation. He's on carvedilol, furosemide, atorvastatin, and amlodipine for also treatment of high blood pressure, high cholesterol, heart failure. He did get the flu vaccine back in October of this year. He received 3 doses of the COVID vaccine, and he had his pneumonia vaccine back in 2008. His family history, his father passed away at the age of 72. He had liver cirrhosis, and his mother passed at the age of 64 due to uterine cancer. Under his social work and history, he is a former 38-year smoker. He used to smoke 1 pack a day, and he quit back in 1990. He denies any consumption of alcohol or any illicit drugs. He is a retired construction worker, and he states that he lives with his daughter who came into the office. She is his caregiver. And he reports that he is surrounded by a very strong family support system. He also mentioned that he still wants to travel to visit back his family in Peru. So that comes to show that he does have a lot of love and support. Here we have his review of systems. He denies any weight changes, any worsened fatigue. He is alert and oriented while appearing. Cardiac wise, patient denies any chest pain or any edema. He does have, under his respiratory, productive cough with nasal congestion. He does report dyspnea on exertion, which is baseline. Currently, no worsened shortness of breath. Um, he GI, no abdominal pain. He denies any constipation or any diarrhea. He denies any dysuria or any urinary frequency. He denies joint pain or any swelling, anything from baseline. Neurologically, he denies any dizziness or any focal deficits, and he feels psychiatrically his mood is pretty stable, and he's sleeping as normal, nothing otherwise in regards to his sleep. In the physical examination, the patient was generally well appearing and no acute distress. His head was normal cephalic, atraumatic, bilateral tympanic membrane, ear canal, and external ear canals were normal. His nares were patent. No oropharyngeal exudates or extraocular movements. They were intact. Prella conjunctiva clear. His neck was supple. No lymphadenopathy, no cervical adenopathy, and trachea was midline. Cardiovascular, his heart sounds were normal, regular rate, no murmurs or gallops or rubs. Peripheral pulse is intact and no edema. He was dyspneic on exertion. There was a cough present and bilateral wheeze on auscultation, no rales or rhonchi or stridor. His abdomen was soft, non-tender, non-distended. Normal bowel sounds were present and no masses palpated. Musculoskeletally, his joint, there was no swelling or tenderness, equal strength to extremities and steady gait with ambulation with a cane. Skin was warm and dry, intact, no rashes or lesions observed. His mental status, he was alert and oriented to person, place, and time. No focal deficits present. Cranial nerves intact, normal reflexes, and appropriate mood and affect. These labs that we have here are values from his previous wellness check. You can see here that his lipid panel was well controlled. His fasting glucose in his hemoglobin A1C, he is type 2 diabetic, which is pretty good for a patient with his diagnosis. His kidney function is abnormal. You can see that his BUN creatinine is elevated and his GFR is low, which does confirm his diagnosis of CKD3B, his CBC white count, RBC, hemoglobin, hematocrit, and absolute eosinophils are also within normal limits. According to his spirometry report, he is considered severe COPD category. For his post-bronchodilator pulmonary function test was at 38%. We ideally want it to be less than, if it's less than 0.7 or 70%, then patients are diagnosed as COPD patients. So the plan for this patient today, even though he came in for an annual wellness check, and we have to ensure that we do all of his annual wellness exams, we also want to ensure that he may or not have any other issues going on that is causing him to present with these symptoms. So we're sending him for a chest x-ray, hopefully to rule out any possible pneumonia, CBC, CMP, serum proBNP, given that the patient is having a cough and he does have a history of congestive heart failure. We want to ensure that he is not fluid overloaded. Could do a hemoglobin A1C, check his lipid panel, TSH, free T3 and T4 to check his thyroid function as well, vitamin D levels and urine analysis. Given that he is coming in with these symptoms, we want to cover him, so we are going to give him promethazine GM to help with cough, Medrol pack as well to help with any possible respiratory inflammations, and a broad spectrum antibiotic such as amoxicillin clavinate for 10 days, and Ventolin to help with as a rescue inhaler, which you can patients who are who have COPD and are in a LABA/LAMA ICS can use a short acting inhaler to help with their breathing, and also follow up in 2 weeks unless there's worsening of health status. And it is also very important to educate the patient to ensure that they do follow up with us in 2 weeks in order to ensure that we can rule out any other issues or monitor any other issues, any possible CHF exacerbations or pneumonia, and educate them if symptoms do not get any better to give us a call prior, come to the office, or need to go to the emergency department if the symptoms are severe. So for the differential diagnosis, we have COPD exacerbation, upper respiratory viral infection, asthma, community-acquired pneumonia, and congestive heart failure exacerbation. The patient does have these symptoms that may fall within these presentations. It is very important for the patient to be educated on the planned treatment that we have for him, not only to ensure that the patient utilizes the treatment appropriately, but also for him to come back within the 2-week period to ensure that we rule out any possible complications. If the patient, for example, has COPD exacerbations, it's only been 3 days, so it's tough for us to determine if it's a COPD exacerbation at this time. Any upper respiratory viral infection, the patient, if he experiences any fever or any worsening of symptoms, we have to ensure that the patient, we can confirm the patient it has or does not have a URI. If the patient, even though he denies any history of asthma, it's important to educate to follow the medication treatment regimen and to reach back to us if any symptoms worsen. And community acquired pneumonia with the chest x-ray and the antibiotics, we hope to be able to see if there is any pneumonia, and we start him to cover him with broad spectrum antibiotics and to continue to monitor the patient, educate. So if there's any further complications, we can intervene appropriately or educate the patient to go and receive a higher level of care, such as in the hospital. And he does happen to have congestive heart failure, which could also be a possibility given that he does have CHF. Be able to educate the patient on treatment or alter or change a treatment based on our previous plan and treat accordingly and have the patient, if need be, receive a higher level of care as well. So classic presentations for patients with COPD include dyspnea, cough or sputum production, clubbing of fingernails, increase in anteroposterior diameter, and increase in the intercostal spaces. Severe cases with abnormal retraction of the interspaces during inspiration. So this can present what is known as a barrel chest. Tripod positioning, which permits more effective use of accessory cervical muscles, such as patients, they kind of like laying against the table in almost leaning towards like a tripod position, and pursed lip breathing with prolonged expirations. So, as per the GOLD COPD guidelines, a diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, sputum production, and a history of recurrent lower respiratory tract infections and/or a history of exposure to risk factors for the disease, such as smoking, such as like our patient that we have in today. And spirometry is the gold standard, which showing the presence of post-bronchodilator FEV1, FEV less than 0.7 is mandatory to establish the diagnosis of COPD. And the goal for initial COPD assessment is to determine if the severity of the airflow obstructions, the impact of the disease on the patient's health status, and the risk for future events such as exacerbations, hospitalizations, or death to guide therapy. So, what are the appropriate tests to make the diagnosis? As per the Global Initiative of Chronic Obstructive Lung Disease, the GOLD guidelines, force spirometry is the gold standard. Force spirometry is a very important test. It is reproducible. It's an objective measurement of airflow obstruction. It is a non-invasive, reproducible, cheap, and readily available test. Spirometry measurements are evaluated by comparison of the results with appropriate reference values based on the patient's age, height, sex, and race. And the presence of a post-dilator FEV1 FVC ratio of less than 0.7 confirms the presence of a non-fully reversible airflow obstruction. And we see here the parameters of the severity. They are converted into percentage rates. So a patient that is considered anywhere less than 0.7 or 70% is, of course, of COPD. My patient is, his spirometry results, as previously mentioned, were at 35%, who is a severe case of COPD, which is in the GOLD 3 standard. As per the GOLD ABE assessment tool we have here, it gives us a view of how to appropriately assess patients with COPD and to determine the route of treatment, the type of treatment that they will need. So, of course, spirometry must be confirmed and assessment of the airflow obstruction and also assessment of the symptoms and any risk factors for exacerbations for the patient. And based on the spirometry results, post-bronchodilation results, we can differentiate which gold standard the patient may be. In our case, our patient is gold 3, which is a severe COPD. And based on the patient's exacerbation history, we can determine what would be the course of treatment for this patient, either course A, for the course A, category A, B, or E. So now that we discussed the grading and the levels based on the spirometry and the exacerbation history, we can talk about pharmacological treatment. So, any patients that are having 2 or more moderate exacerbations or 1 or more leading to hospitalization, it would be recommended to have a LABA/LAMA. However, you may also consider a LABA/LAMA ICS if their eosinophils are equal to or greater than 300. And patients with group A would be okay with a bronchodilator, and patients with group B would be appropriate to have a LABA/LAMA for treatment. So, according to the Global Initiative for Chronic Obstructive Lung Disease, treatment is based on what would include a LABA/LAMA as the highest ranked treatment for patients to reduce COPD exacerbations. The use of LABA/LAMA ICS is typically considered for patients in Group E with eosinophil counts less than 300. However, there is no direct data in the literature concerning initiation of triple therapy in newly diagnosed patients. However, it is thought that available studies performed and treated patients provide a rationale for considering this treatment option as initial therapy for patients with high eosinophil counts of greater than 300, along with a rescue short-acting bronchodilation to be prescribed for immediate relief. Oxygen therapy is also appropriate. Long-term administration of oxygen to patients with chronic respiratory failure has also been shown to increase survival in patients with severe resting hypoxemia. So even though our patient does not have severe resting hypoxemia, he does, and his oxygen saturation is at 97% at rest. He does have desaturation when he exerts himself down to 85%. So for him, it is considered appropriate to give him oxygenation therapy, which he does have at home, and which also helps increase his survival rate as well. So it's a good option for him. So our patient is on a combination of LABA/LAMA ICS, and it's important to have certain considerations prior to initiating ICS treatment. Our patient, he is under what I see, if I want to show here the yellow category. He does not have an eosinophil greater than 300. However, his blood eosinophil is between 100 and 300, and he's had a history in the past of exacerbations. For him particularly, it's appropriate to introduce a LABA/LAMA ICS for treatment. He's had good response to the LABA/LAMA ICS treatment, and according to the gold standards guidelines for treatment of patients with COPD, he is still considered a favorable use for this patient. However, given the current presentation, we also have to ensure that we create a plan to rule out any possible differential diagnoses prior to considering any modifications of his COPD treatment as well. And that is my presentation for you today. Thank you, and I hope you all have a great day.